Well, hello and welcome to Top Med Talk here at Anesthesiology 2025. It's the annual meeting of the American Society of Anesthesiologists. I'm Desiree, Chappell, your host and co-editor-in-chief, and I'm super excited to be here in San Antonio to have the second discussion with some of my favorite people. I will tell you, one of our favorite podcasts we've done here on Top Med Talk is talking to a group from the U.S. Army. And so we have the privilege to do that again today. So I'm excited to reintroduce a fan fave, I do have to say. We have Colonel Michael Patzkowski. Mike, thanks so much for coming back.
Thank you, man. Appreciate it.
It was a great conversation last year. It was so enlightening for all of our listeners.
Yeah, I hope the next one will be just as good.
I think so, absolutely. You brought some folks along with you, a little bit different this time. I'm going to go ahead and introduce them, but if you have any other stories to tell about them, you know, it might be okay. No. Sure. We have Lieutenant Colonel Dan Raboin. Dan, thank you so much for coming and chat with us.
Thank you for having us.
Yeah, that's great. And then we also have Lieutenant Colonel Jordan Lane. Jordan, thank you.
Yeah, thank you. Great to be here.
Well, for our listeners, I always ask you guys to kind of give a little bit of your background, where you're from, where you're currently stationed. So, Dan, why don't we start with you?
All right. Well, I'm originally from Bristol, Connecticut, which is the home of ESPN.
Oh, I did read that in your bio.
Yeah.
I was like, that's great.
Yeah, that was a mandatory field trip.
That's great.
So I did ROTC, and I was not smart enough to get into West Point like these two. So I did an ROTC scholarship instead, and I actually became a pharmacist. So I worked as a pharmacist for 6 years first, and then decided that I'm at least as smart as these guys. So I went back to medical school and eventually doing an anesthesiology residency. I've deployed for both a humanitarian mission and a combat mission. And presently, after a brief stint in the Washington, D.C. area, I am now back in San Antonio here.
Oh, you're stationed locally then?
Stationed locally. I work for Mike again. Great. And really excited to be back here in San Antonio.
Yeah, that's fantastic. Well, thank you for your service.
Thank you.
Thank you for the alternative route is not a problem. We hear about that all the time, so that's all good. Jordan, why don't you tell us a little bit about yourself?
Yeah, so from Data Point, California, so warm, sunny California. Then went to West Point and was a Black Hawk helicopter pilot for a number of years, doing 2 tours to Iraq. And then during that process, did my prerequisites, went to med school, and then did all my anesthesia training at Walter Reed. Currently in warm, sunny Honolulu, Hawaii at Tripler Army Medical Center, where I'm the chief there. Yeah.
Oh, great. You're the chief of anesthesia there.
Yeah.
Okay, fantastic. Well, thank you for your service.
Thanks.
Yeah, and Mike, for our listeners, why don't you remind us a little bit about your journey and where you, what you're doing now?
So I grew up in northern New Jersey, about 30 minutes outside New York City. Went to West Point for undergrad. Went to the Uniformed Services University, our nation's military medical school, for training. Did my anesthesiology residency here in San Antonio at Brooke. Did a clinical fellowship in regional anesthesiology at Walter Reed. And then I've been, kind of bouncing around different Army places for most of my career. Currently, I'm the chair at Brooke Army Medical Center for our 2 training programs there, and I'm the consultant for Army anesthesiology to the Surgeon General. So I get to answer all the questions from the top. So.
all of them. I'm sure there's some good ones. We won't ask you what they're asking these days, so we can only imagine.
Lots of questions.
Well, again, thank you for your service. Now, I'll remind our listeners, you can check out the podcast from last time, because I think we did a really good overview of what it means to be an anesthesiologist in the Army and kind of the process and how you can get into that space. I encourage everyone to listen, because it was very, very enlightening for those of us who work in the civilian world to learn about how the different tracks, so like ROTC, or if you go straight into a military university. But please do listen to that. Today, though, we thought we'd focus a little bit more on a topic, Mike, that you brought up, clinical readiness within Army anesthesiology. So I wanted to ask you, first of all, what does that mean?
Right. I think Jordan's got a good perspective on this, because we'll probably set the stage of what does the Army think readiness is, and then that's what is medical readiness.
Okay.
So
Yeah.
Jordan, tell us from your time.
Yeah, so I think a big focus on a lot of these jobs is the Army component of it. A lot of Army jobs are have a civilian element to it, but are Army specific. So you think, helicopter pilot, you think infantry, they all have a different variety of how much of it is civilian relevant versus like a very military primary like focus. So like say helicopter pilot aviation, you've got to learn all the federal, the rules. You've got to learn how to fly, be a good pilot stateside. But then also there's recognition that the Army mission is completely different than a lot of the civilian mission as well. So the readiness component for a lot of these Army specialties is focused on, learning what you if you're signal, learn like the communications aspect, maybe get certification on the civilian side, but then also focus on what you're going to be doing at hand, and what you would be needed to do in a deployment situation. So, with aviation, that'd be like you're focusing on the civilian side, but then also you need a lot of the training, a lot of the focus is going to be on what your deployed task would be. I think when it comes to medicine, like traditionally it's been focused on, hey, if it's good enough for the civilian life, then that's like you're certified, you're a credentialed provider, then you're good to go. You're ready for the deployment. When often we kind of more focus on the civilian side versus the military side and the specific tasks and the kind of the breadth you need in order to be able to be ready for what comes ahead. So
yeah, to kind of give you a breadth of like what our starting state was, like, so I graduated from the residency program here, level 1 trauma center. I've got this great skill set. I'm taking care of really sick patients. Then I go to Fort Bragg, North Carolina, where I mostly take care of really healthy patients.
Young and
they jump out of airplanes, so they break a lot of
They
ankles. So
break
we're ankle fractures, center actions. I did tons of nerve blocks. But what I hardly ever took care of an acute trauma. I went 4 years without placing a central line. So all these, but more important than the procedures, it's just that mental, that thought process. So you had this really high-end skill set, and now you would feel it slowly atrophying, and like you were left as an individual to find ways to make yourself more, whether that's doing, off-duty employment, finding someplace to do, or like I was very lucky. I was able to made a lot of friends and a lot of relationships. I got to go do some stuff with the special forces and then their medical training, which is a ton of fun. And anytime you have to do any training that requires signing a non-disclosure agreement, it is a good time.
You're going to get a good experience.
Not everyone got that experience, and you had to have the right personality and go be someone who's going to seek that. So, you were a credentialed anesthesiologist, but were you really ready to do the mission you'd be required to do?
So it's all about kind of standardizing then how you approach readiness for your entire group.
And I think that's one of the great things that Mike has done for our specialty since he's taken over as consultant. It started with his predecessor, Dave Ruffin, but Mike has really taken and run with it. And I can let Mike probably talk a little bit more.
So the thing with the Army is, readiness to the Army is a consistent cycle of evaluation. Like every unit gets evaluated doing their deployment job, and they're certified that they're ready to go. It's something that it's been proven that they're ready to do their job. In clinical medicine, when we talked to higher ups years ago, it was, how do we know the Army medicine's ready? Well, we're privileged. We're privileged to do all the things, but I can't show you. I can't do an evaluation. We can't necessarily do all the exercises because a lot of the anesthesiology inventory is in the fixed brick and mortar facilities. They're not in those deployed units. So if I'm doing a great job at Walter Reed or BAMC or Tripler, that's not necessarily in a deployed environment. And
you have everything to your disposal.
Right, exactly. And at Brooke, you're taking care of level 1 trauma, which is very relevant to the battlefield. But a lot of our other centers, they don't take care of level 1 trauma, so less relevant to the battlefield. So the shift came from senior medical leaders talking to senior Army leaders saying, we need something that looks like what the Army does. We need to know what are the things that you need to do to be successful on the battlefield, and we need to be looking and assessing at those things, not just, I am privileged and I am currently working in the OR. That is not good enough.
Yeah. So you talk about deployment, and I mean that we kind of loosely understand that, but you're talking about going to other countries, worldwide deployment that may be in a facility but may not be, right?
Right. So a lot of our facilities when we're deployed are, not permanent. They're semi-mobile. They're semi-fixed, right? Sometimes we take targeted opportunities, buildings, areas of convenience that we can if you're in a built-up area. If you're not in a built-up area, like a lot of the Middle East, you have to bring all of your own equipment. So we went from, hey, we're privileged to do these things, to ideas like KSAs, knowledge, skills, and abilities, right? Certain things that demonstrate that you have the know-how to do the clinical care that you need. Things like the individual critical task list. A certain set of procedures that someone could actually watch you do with a checklist, go, no go, that you can do this complex peripheral nerve block with a catheter, that you can do transesophageal echocardiography for resuscitation. You can do these things, and then you take care of polytrauma. So for me, the biggest thing is anesthesiologists deliver an anesthetic, but also resuscitate at the same time, right? These are patients who normally should not go to the OR because they need a resuscitation, but you can't. So you've got to do both. So taking care of level 1 polytrauma, resuscitating with blood products as a regular feature of your practice is really important, which sets up a lot of the training agreements that we'll start talking about here.
Yeah,
shortly.
and the other really unique thing is that Uniform Services University, and I believe Jordan also has a MOCA simulation center, and the nice thing about having our own military ones is we can build in some very military unique situations where you are performing your duties in more of an austere environment. You don't have all the bells and whistles and tools that you're used to having, or problems. You know, how many times have you ever seen a civilian trauma center, someone comes in with unexploded ordnance? Well, it doesn't happen, right? But that's a very unique military conundrum that you have to have to successfully handle it. You have to think about it ahead of time instead of making up on the fly.
Yeah. So it's a like competency checklist, having mock, what we would call like mock codes and mock drills and things like that. It's kind of what you're talking about with your the MOCA simulation and things like that?
Yeah, I mean, so you know, like aviation specific simulations big on practicing those things you can't practice in real life. You know, like the emergency situations, the things you don't want to have to deal with, but that you need reps in. So I think the idea is simulation for anesthesia as well is the same focus, that it's those once in a career, you know, couple, you know, like, or something like, it could be a deployed environment, something you're going to deal with, but you don't have to deal with in the brick and mortar of the hospital you're working at. So that's kind of the tie-in. So.
Why don't we talk a little bit about some of the barriers for this? Because, I mean, all of us, you know, in everyday practice we just kind of do these things. I'm sure it's a little bit more complicated for the level and scale of what you're talking about.
Yeah, it's just trying to find access to those patients, right? And it depends on your health system and what you're able to do. What is your patient population, right? If you're trying to do level 1 trauma, if you're not in an urban center, you're not going to be able to get that if you're in a remote area, right?
Yeah.
A lot of our facility affiliates, most of them do not have access to civilian trauma because of U.S. code, DOD regulations, and what we're able to do, right? So there's some policy things that need to be worked out. So over the years, the Army's had some different ideas. They started the AMCT3 program, which was basically we were going to take Army clinicians and put them into civilian hospital systems as on a kind of a permanent basis. You'll be assigned there, right? So you're going to do a 3-year tour at, you know, Southwest General in major U.S. city, and, you know, your surgical team will work there. That's how we're going to get after it. But there were some issues with that. When we take our military folks out of our own health system, the Defense Health Agency, we lose manpower, and we're trying to do ORs and take care of beneficiaries and do all that. So something we've tried to shift to is what's called these training affiliation agreements, right? And so where almost all of our contingent can spend some time of their duty day at a level 1 trauma center. So I can spend, you know, a quarter, maybe up to a half, depending on staffing, at a level 1 trauma center, but I can still support the home mission, which is to take care of soldiers, airmen, and Marines and their family members at home. And so that was basically the barrier is, how do we take care of our primary mission, but how do we still stay ready at the same time? Because military medicine does 2 jobs, the deployed mission, but also take care of everybody at home.
At home.
We have the same tensions as everyone else. We're short anesthesia
Staffing
providers too.
is not unique to us.
We have
right?
to get these missions done, and it's really hard because in the military system, our hospitals are actually run by the Defense Health Agency, not the military departments. So there's a kind of that conflict because the Defense Health Agency, their job is patient care, whereas our job is patient care, but also being ready. And sometimes it can come into a conflict, and convincing the military treatment facilities leadership that you can give up some of your providers' time so they can go do these things for readiness, and like, how do we sell that to these MTF? And I think Mike's done a really good job telling MTFs, if we set up these training agreements, I will try to send you additional people And
Yeah.
And conversely, you have the carrot. He also has a stick saying, if you won't let our people do these things, our anesthesiologist, we may consider sending them to other places. So
Oh, yeah. Well, it sounds like a win-win, really, if you can get these at clinics. So walk through that just a little bit more.
It does. It can be a win-win. Military leaders, commanders have responsibility for training people. There's a lot of bandwidth. There's a lot of people to train. There's a lot of stress.
Yeah.
Working in the C-suite, how do I take care of everybody in an organization? Yeah. If people from the ground up are not bringing ideas on how to get them their readiness or whatever it is on the civilian side, leaders can't do it all.
Yeah.
They don't have all the answers. So they really need people to push answers up from the ground of what will work. And so that's what we've done with a lot of our chiefs that are different places is, hey, these are some ideas that can help us get our readiness. Sir, ma'am, this is our idea. We just need your support and blessing on it. You ultimately control where everyone goes and what they do, but we've got a plan that will take care of the home side mission and our deployment mission. Can we do this? And we've been pretty successful with that so far.
Right. Jordan, do you want to tell us, and if you're the person, or if not, talk about it, but what is an affiliation with an example an affiliation looks like? So Mike just mentioned you may spend part of your time here, part of your, but give us a case use example.
Yeah, so we recently signed an agreement with a local trauma center by us. So it's we don't have to travel. It's no flights. It doesn't cost the military money per se. There's nothing like that. But that I can send my active duty people there and work at a level 1 trauma, because we're a level 2 trauma center at Tripler. However, like was being said, it's sometimes hard to actually get those patients through the gate and to see significant trauma. Sometimes we get it, sometimes we don't.
Yeah.
But then having a partnership with the local hospital that then allows you to get trauma and then also just take care of sick patients that may be different than the military dependent, the active duty military, the retiree population. That it gives us the ability that when we have the people that we can take care of our home mission, we can then also send them to the major place and get more experience and more readiness for the future. So.
Yeah. It kind of sounds a little bit like you're creating a bit of a locums team too. Like you come in, and is it like that, or am I thinking it is the wrong way?
Not
Like you're kind of helping
a little
out.
bit, because
like that.
by the agreements, we are not allowed to displace a permanent staff member. So part of it is
Sure.
if there's a day we couldn't show up, that hospital still needs to function.
Yeah.
And we're not here to take anyone else's jobs. So that's part of it. And we also kind of decentralize it, letting the MTFs decide, and the local anesthesia departments decide, how is this going to work for you? So at Walter Reed, we're partnered with Major Trauma Center in Baltimore, and those folks go there one day a week.
Yeah.
Whereas at Fort Belvoir, they kind of set their training agreement up with another facility in Fairfax County, where they'll go for a week at a time. So an anesthesiologist will go for a week at a time, and then come back, and then the next week another anesthesiologist goes.
So do you not want to think of them as staff per se, or would they be?
No, they are. So they have the same kind of staff privileges that the ordinary staff there. The nice thing is that the host facility does not incur any really much indebtedness to this, right? So there's no bill associated with this. The only thing that the military asks is that the host facility cover the malpractice insurance. That's really the only thing that the host facility does. And in return, you get a privileged, qualified staff anesthesiologist who's motivated, who comes to work on time, who's polite, who has values, is going to come integrate into your workforce. So I think it's really a win-win. And for most places, when our military people do come, that means you've probably got an extra person on hand to take care of an extra emergent requirement that comes up, or someone can give an extra break, or take care of some other leadership things they do when the military folks are around. So it's a very flexible agreement, and every place could use more help.
That's what in my mind thinking. Again, I work with North Star Anesthesia, and I'm thinking, wow, wouldn't it be great to have someone to be able to partner with that for all of those reasons that you said, and to have that extra person in. It really does sound like a win-win. So if people are interested in talking to you all and maybe looking at an agreement like this or an affiliation, what's next steps for them?
Well, almost all of our major medicines, I've kind of talked to those local chiefs, says you need to go and find a local group, find a local facility that has exposure to these kinds of patients, and start having that conversation if this can work out. So there's support from Army Clinical Medicine to do this, right? The other thing is finding the dance partner. You know, who's going to be the other end of that equation. And so Jordan can talk about it as he kind of went through that process of, you know, how did I get in touch with these folks? How did we kind of talk about this? How did they get to know you and you know them to say, hey, this might work out?
Yeah, so I think first is trying to find like who you want the agreement with. You know, like is it a private group? Is it a academic center that that's 100% staff? Is it manned by a private group? In our case, it was a private group. But then also just like looking for established relationships you already have. You know, like we had one or two people doing off-duty employment like on their free time that had worked and already integrated with the group. So they had seen some of us, you know, previously, and then just meeting one-to-one, talking, kind of explaining what you actually want, because once you sit down and talk about it, it's a pretty obvious win-win once you get over any sort of administrative type paperwork hurdles. So really it's trying to, you know, have a good reputation, trying to talk to people one-on-one and kind of
So can the dance partner come to you?
Oh, absolutely. Oh, absolutely, absolutely. You know, through all those, you know, clinical channels that, you know, we have a lot in any major city or environ. You know, people talk to people. Like anesthesia providers talk with amongst each other. We kind of all know what's going on around in town, and so if that's something attractive for you know, a partner is saying, hey, this is what we could offer our military folks. So these are the kinds of patients we see. These are kinds of the cases we have. This is how we would be flexible with things. And the beauty of the TA is it allows training to happen, but it doesn't mandate how it happened, right? And so...
some like guardrails around it, but there's nothing that is
right.
so prescriptive.
So you know, the leader at each facility decide what's going to work for them. Is it one person a day? Is it one person a week? Is it, you know, every third week?
Yeah.
Do you need to know the week before, the month before? All of that is negotiable, and that's the beauty of it. It can work for anybody.
So really quickly, talk through what are some of the main skills that you want to make sure, because I know we're thinking level 1 trauma, but I can also think regional anesthesia training, you know, lines and things like that. Are those all things that you're trying to get trained on, or what's kind of a short list?
I would say the most thing is the exposure to the acutely traumatized patient, right? Obviously, the fresh trauma that comes in is obviously the most beneficial.
Yeah.
You can't always time that right. You can't always get the shift right. But that patient that's probably within that first 24 hours of that initial injury and ongoing resuscitation, that's what you want. We want the polytrauma patients, the isolated, I just have a tibia fracture and nothing else is wrong with me. That's not really exciting.
Yeah.
The patients requiring blood products.
Yeah.
Those patients will usually require all the other things that we want to do. Central line placement, regional anesthesia, advanced resuscitation with monitoring, all those kinds of things kind of follow.
Yeah.
So those are kind of the things that we're looking for.
Okay. So really focusing more on that trauma piece.
Exactly.
Right.
Exactly.
Yeah, and I'm putting my critical care hat on.
Yeah.
Here. And I can say even day 2 or day 3 trauma, because a lot of times those patients are incredibly challenging because, you know, on their initial resuscitation, they get this massive resuscitation, and now they're volume overloaded. And how do I take this patient to the OR and make them maintain their oxygenation while also giving the volume back that the surgeons are losing?
Yeah.
So and as we go towards our potentially large-scale combat operations, we're thinking that we will have to keep our casualties in place a lot longer. You know, in the War on Terror, within a week, we usually had our patients back stateside. That may not be possible going forward. So it's going to be a good skill to be taking care of these patients longitudinally.
Yeah.
So, you know, if the system has like a multidisciplinary trauma room or trauma service that takes care of general surgery, orthopedics, those are kind of things. You know, if there are overnight in-house trauma call shifts, we would love to do those. Some systems love that. The host doesn't want to do that, so you can do it, no problem. Other places like, no, we incentivize our people to take those shifts, so we're going to have you do the daytime stuff. So again, it can be very, very flexible, and once the agreement goes, it's a constant, you know, talking with your dance partner. How is this going? Are you getting what you need to? What are we seeing? And then adjusting on the fly, which is really nice.
Continuous kind of improvement of the program.
Absolutely.
And everything else. Put our quality hats on, right? All right. Well, anything else that you would like our listeners to know about this program? Where can we get some more information? Who would we reach out to specifically? Because I'm thinking just in my mind, wow, there could be a couple sites that I'm like, this could actually work really well.
I would say if you have a military treatment facility in your local neighborhood.
And local, are we talking minutes, an hour, couple hours kind of thing?
Yeah, I would say probably within an hour to 2 hours is
Okay.
kind of the radius of most people are looking at. If you've got a trauma population and you would benefit from having some military people come around for the skill infusion, the values infusion, and some extra hands, talk to those providers that work there and say, hey, are you interested in partnering with us because we would like to partner with you? And it just starts with a conversation.
Yeah, fantastic. Gentlemen, I cannot tell you how much I appreciate coming and chatting with us on Top Men Talk. Again, super enlightening. We've had lots of conversation about workforce and about staffing and the economics of anesthesia, and this fits really well into that whole picture too. So again, thank you for your service. We all appreciate that, but thanks again for coming on Top Men Talk.
Thank you for having us.
Yeah, thanks so much.
Thank you.
Appreciate
Cheers.
it.
All right. Thank you for listening to Top Men Talk. You can always find us at topmedtalk.com. We're on your favorite social media platform. We're on your favorite podcatcher. If you find us there or on YouTube or anywhere else, give us a thumbs up, give us a star rating. Let us know what you want to hear more of, and you can hear more conversations just like this. So thanks, everybody, for listening. Oh, one more thing. We want to thank the U.S. Army for supporting Top Men Talk, as well as the American Society of Anesthesiologists. Without that, Top Men Talk can't be free and open access to the entire world. So thanks, everybody. Cheers.
Thank you.